Okay, so my camera glitched. So before unhooking this and discarding of it, after suctioning for the patient, I would rinse this in my sterile saline cup until all the secretions are clear from all of the tubing. This is my non-dominant, not clean hand. So I would rinse this and then re-oxygenate the patient while I'm rinsing it. If I was completely done, then I would wrap it up, remove my gloves, and with it in the glove and discard, and then return the patient's oxygen settings back to normal, as ordered, and then I would document the procedure, how the patient handled the procedure, amount of secretions, consistency, color, type, smell, any of that. Since I'm doing trach care, I am not done yet, so I would perform hand hygiene, don new sterile gloves since I'm doing trach care, and then here is my little patient. So we're going to use this as my inner cannula. So my sterile water from earlier, I'm going, after I opened this earlier, so I'm going to dump this out on my sterile field. And then if my patient wasn't in this area for the camera, I would have this sitting here. So we're just, there we go. So if my patient wasn't here for the camera, obviously they'd be in the bed, so this would be in my sterile field. Still making sure not to drop my hands. Making sure nothing's touching the outer 1-inch border. So I would put saline and peroxide. And then remove the inner cannula, and I'm going to drop it in my peroxide and let it soak. And then I would take my this pipe cleaner, and scrub all around it, make sure I get all the secretions off, get everything good, and then I could go inside it with my pipe cleaner, clean all the inside really good, which you can't really tell with me doing this, but make sure to get all around the edges, and then drop in the normal saline, and then I would remove it and use my other pipe cleaner to go in and out and around and get all of the excess saline and moisture off of it. That way when it's reinserted into the patient's outer cannula, they can't taste the peroxide and the saline and all of that. I'm also going to clean the outer cannula and around the stoma and the head of the trach with my sterile Q-tips. So then I would just go in and around and then throw that one. And then for the stoma, which you can't see, but normally I'd be able to get under there, I'm going to go around, starting closest to the center of the stoma, and then throw, and then go grab another one, go a little further out around, throw another one out more, throw, and then out more and throw. And so I'd be cleaning, going from least contaminated to most contaminated on the patient. If the Velcro straps were dirty, then I would change those as well, but I'd make sure not to remove them before I have the clean. So remove one side at a time before changing them. So take one side off, weave it in, and it's really hard to show because I don't have straps or like roll straps. But I would take one side, weave it in, and then once I get around, remove the other side and put the new one through. And then also apply a new sterile gauze around the trach. So it would be similar to that. And then I would document, return their oxygen, document trach care, how they handled it. I already documented the mucus from the trach suctioning, but if I was doing just trach care, then if there was any secretions or anything, I would document those, how much, consistency, color, and the same things that I'll document for the suctioning. For the saline, I have not used it all, so I would recap it, leave it in the patient's room, and label it with the patient, the time that it was open, and the date, so that they know when it's expired, because it's only good for 24 hours after being opened. Then I would clean up, take off my sterile gloves, perform hand hygiene, let the patient know where the call light is, make sure they're comfortable, they're reoxygenated, assess them further, and then let them know when I'll be back. And that's it for trach care.